ways that I'd like to start the conversation is just to talk about how germline testing for patients with leukemia really impacts therapy. For those of us who take care of children with cancer predisposition syndromes all the time, we know that for patients with brain tumors and solid tumors, the timeline in order to have these evaluations done isn't really critical. But for patients who need a bone marrow transplant, especially if you are considering a matched sibling donor, this is the highest priority for a cancer predisposition evaluation in your institution. And another thing to consider is if you have a patient with leukemia who's really not following the rule book, they have more toxicity to therapy, they're having more holds, they're having delays, they're ending up in the ICU, they have unusual infections. All of these are red flags that your patient may have an underlying genetic reason that they develop leukemia and potentially an overlapping immunodeficiency. An early cancer predisposition evaluation is helpful because it takes much longer for a cancer predisposition evaluation to be done in patients with leukemia, and I'll talk about that a little bit later. So it's important to recognize that germline testing should be done on non-tumor tissue. This is, of course, not an issue for our patients who have brain tumors or Wilms tumor or rhabdomyosarcoma because the blood is not affected. However, when we have patients with leukemia, the blood is the tumor tissue and should not be tested. So common samples that we use for germline testing are blood, which we do the leukocytes, so that is the actual DNA that is extracted since the red blood cells and the platelets do not contain DNA. The buccal or cheek swab, which is a combination of the two types of tissue, or a saliva sample. So it's important for you to understand when you are evaluating a patient with leukemia for a germline predisposition that if you are going to use any of those samples, they're going to have tumor in them, and you need to understand that when you're looking at the results. And the main risk that you're going to run into is somatic variant contamination, because all of the genetic changes that have occurred in the tumor are going to show up as a result. This is a visual to help you understand exactly how mixed this population is. When we think of doing a cheek swab or having the patient spit into a tube, we think that it's all just tissue from the cheek, but it's not. As you can see, all of these little purple dots in there are leukocytes, and those, if your patient is not in remission, are all cancer cells. So what you are looking for on the right is this beautiful fibroblast layer where, as you can see, there are no little purple dots, there are no leukocytes, and there's no tumor tissue that's going to mess up your results. So the gold standard for germline testing is cultured fibroblasts. They contain new leukocytes, so it's pure germline DNA, and this means that your results will never be wrong. It is obtained via a skin punch biopsy, and unfortunately for patients who need to go to transplant, they require about 4 to 8 weeks for them to grow into a perfect layer and for the DNA to be extracted. This is why when you have a patient with leukemia and you are concerned that there's a family history of cancer or a family history of leukemia, you need to act quickly. It is relatively easy to do the skin punch biopsy at the same time that you're either doing the diagnostic bone marrow or one of the lumbar punctures at the very beginning of therapy. So you have multiple opportunities when your patient is asleep or when your patient is going to already have a procedure to add a skin punch biopsy on. And one of the things people often ask me is, well, shouldn't we only do this for patients where we think that there's cancer, like where we think there's cancer in the family? And the answer is that at least in the research that we've done at the University of Pittsburgh, there are no good predictors for leukemia predisposition in children, and so you can't tell who has a genetic reason for their leukemia and who doesn't. And it can be roughly 10 to 20% of your children, even higher in some ethnic populations, who may have a genetic reason. And again, if you're looking at a sibling transplant in that situation, the worst thing that'll happen in your institution is that you'll transplant an unaffected sibling who has the same genetic condition into the child who already has leukemia, and essentially you have not helped either child. There are a couple of leukemias that we absolutely know need a cancer predisposition evaluation. Many people know that hypodiploid ALL is a red flag for Yerevan syndrome. However, I do not recommend single gene TP53 testing in this case. I still recommend a broad leukemia panel because I've had numerous personal experience where it ends up being a different cancer predisposition syndrome, and the Yerevan testing was negative, but there was another reason why the child had leukemia. Another thing people ask me a lot about is, well, when we sequenced the tumor, it didn't have any genetic changes, so doesn't that mean that the child doesn't have a cancer predisposition syndrome? And that is also categorically false. The tumor genetics do not predict the germline. So if you don't see a TP53 mutation in the tumor, it's because the tumor DNA is so changed that it will sometimes completely lose those chromosomes, and therefore you're not going to see a point mutation, you see a complete loss. And so don't take one as an explanation for the other. They should both be looked at separately. So many of you may be familiar with the fact that there are guidelines for children who have leukemia. The United States has the National Comprehensive Cancer Center Network, and of course there are the European guidelines as well. When we follow the American guidelines, they specifically say that any child with AML or any of the myeloid leukemias, MDS, these are actually, interestingly, the adult guidelines, but they say that any child with monosomy 7, anybody who was diagnosed with AML under the age of 40, any child who has a family history, any child who has severe aplastic anemia, and any child where you are considering a matched sibling donor should have a cancer predisposition evaluation prior to going to transplant. So if you are getting pushback from either insurance or from other people at your institution who are like, why are we all of a sudden being asked to do this? These are some good evidence-based guidelines to help people understand why this is so important. And that's all I had. My part is actually very short and simple, and I think depending upon how you're doing questions, I am happy to answer any questions.